10 years of training. What have you got to show? Certificate on the wall. Now you're on the dole. Everyone kept on saying how we need more GPs. Thought I'd have job security. Instead I'm sat here watching daytime TV. Where did it all go wrong? I tell you it's us. Additional roles, reimbursement scheme, it's us. Mess with the market. Something always goes wrong. Driving a crisis without your headlights on. The PCN now, getting staff almost free. A dozen health coaches, 2 dog walkers, but no GPs. Where did it all go wrong? I tell you it's us. Additional roles, reimbursement scheme, it's us. It stripped you of your job, now it's gonna give it back. Could be cut anytime, there's a dozen caveats. Doesn't pay that well, but hell, I tell you it's us. Additional roles, reimbursement scheme. 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 Additional roles, training. What have you got to show? Certificate on the wall. Now you're on the dole. It's Friday, the 1st of November, and this is the Hot Topics podcast. Welcome, everyone. Thanks for joining us once again on the Hot Topics podcast from NB Medical. Neal Tucker here as usual, and we've got a jam-packed podcast today. So later on, we'll be having an interview that's been put together in conjunction with Prostate Cancer UK. I'll be talking to Alex Norman, a GP from Surrey, and Oliver Holson, a consultant radiologist who specialises in prostate cases. We'll be chatting about a new consensus paper that recently published in the BJGP, talking about prostate cancer and the role of PSA testing in asymptomatic men. In the meantime, we are going to look at 2 new papers on the drugs of the drugs of the decade. So firstly, one in the New England Journal of Medicine this week on semaglutide for helping knee osteoarthritis. And secondly, a new one in the BMJ looking at the role of SGLT2 inhibitors in preventing kidney stones. First, a look at what's going on in the world of NB Medical. So next Thursday, that's the 7th of November, we've got a live webinar of our latest Hot Topics course. That's the Hot Topics Autumn 2024. So join us for that. On the Friday, we've got our Hot Topics Primary Care Cardiology and ECG course. This is fantastic. I learned a huge amount going on this, a brilliant reminder of how to look at, interpret ECGs and a range of other cardiovascular issues. So do check that out. On the Saturday, we've got our abnormal bloods course, and then there's more besides. So the following week, we've got our men's health course, we've got palliative and end-of-life care, and then our new urgent care course coming up as well. So it is all going on. Don't forget, if you sign up to MB Plus for just over £300 a year, you can come on all of these live webinars. You can have them all on demand and much more besides as well. If you're going to come on more than one NB course a year, it will save you money by joining MB Plus. And saving money is something probably we're all being a bit mindful of thanks to the new budget. So that's the big news this week. We've been waiting for months for Labour's first budget, and now we have it. And it's generally positive for the NHS, but maybe not so positive for general practices. I get it. There is no magic way to pay for things like services such as the NHS without someone actually paying for it. That's not going to help partners and practices that are already struggling to balance the books. And after all the acknowledgements that strong general practice is essential to a well-functioning NHS and that we're going to see big changes here and hopefully funding and support, let's be honest, it feels a bit disappointing. Once again, general practice is left out in the cold and all the cash ends up going to hospitals. Unsurprisingly, the BMA is up in arms. Let's see what happens there. I think if you are a practice in England and you're undertaking some collective action at the moment, now is not the time to stop. Okay, no messing around today. On to the research, and we'll start with our first paper in the New England Journal of Medicine. This is once weekly semaglutide in persons with obesity and knee osteoarthritis. This is a really interesting study that raises lots of different interesting areas. So let's start off with osteoarthritis then. So that's a big problem. We all know that's a big problem, and there's lots of problems with it. So medicines, for example, are not great generally, or rather I should say analgesics. So paracetamol, that's been removed from most of our national guidelines in the context of osteoarthritis because the data doesn't really support it does very much. Anti-inflammatories are more effective, but we all know the problem with those, particularly in older people who are the ones who tend to get osteoarthritis. Exercise works. So physiotherapy is helpful if people do the exercises. Exercise itself without physiotherapy, that could be useful too. But the bottom line is people are just not great at actually doing it, which then leaves you with surgery. That's obviously very invasive, costly, time-consuming, and comes with potential complications. Now, one of the major drivers for osteoarthritis of the knee is obesity, and there's obvious reasons for that. It puts more stress through the joint, and then there's some less obvious reasons as well. So visceral adipose tissue is pro-inflammatory, and we're beginning to understand that osteoarthritis is not an entirely benign process. There is often an inflammatory component as well. Plus, that visceral adipose tissue also secretes mediators that increase pain. So the GLP-1 receptor agonists then feel like a pretty logical treatment for this problem. And to quote the editorial, they not only facilitate weight loss, but have a pleiotropic, anti-inflammatory and immunomodulatory effect. Pleiotropic, that's a good word. Sometimes I wonder if with these editorials, if one of the main goals is to try and make sure that you sound smart. They also point out that GLP-1 receptor agonists may help by acting not just locally where the arthritis is, but also centrally, which then raises the interesting question of whether these medications might be effective for osteoarthritis in people without obesity. Anyway, that's a discussion for another day. This was the STEP 9 trial. So you'll be familiar with some of the other STEP trials. They're all the ones we've been talking about on the Hot Topics course in the podcast over the last 2 years relating to semaglutide. And the method follows a similar pattern. So this was a randomized controlled trial. It was not a big trial. It's about 400 participants. Entry criteria was to have obesity, so a BMI of over 30, and clinical and radiological diagnosis of moderate knee arthritis. Participants were then randomized in a 2-to-1 ratio to either semaglutide or placebo injections given over the course of 68 weeks. So they had the usual 16-week gradual up titration to get them to the maximum dose, which is 2.4 milligrams of semaglutide. And then the treatment was carried on for the rest of the year. The primary endpoints were change in body weight and change in WOMAC score. So the WOMAC score is a pain score rated from 0 to 100. Just to give you an idea of the study population, average age was 56, predominantly female, predominantly white. The weight on average was 109 kilos and BMI 40, so 41% had a BMI of over 40. That's important to know because, of course, you could be included in the study from a BMI of 30, but most people were much heavier and had a much greater BMI than that. And at baseline, the pain scores were about 70 in both of the groups. The results showed that there was a mean reduction in body weight of 14% in the semaglutide group compared with 3% in the placebo group. Not a hugely surprising result there, but the pain scores are what really matters. So the WOMAC score in the treatment group went down by 42. Remember, it started at 73 and it went down by 42. It's an absolutely huge difference. There was a big change in the placebo group as well. So that started off at 67 and went down by 28, still giving a 14-point difference, which is reported as statistically significant. But I think it's quite interesting that there was such a marked placebo response here. Nevertheless, that doesn't diminish the benefits seen with semaglutide, and the authors conclude that this randomized double-blind placebo-controlled trial showed that treatment with semaglutide alleviated pain related to OA of the knee among persons with obesity and knee osteoarthritis, and that these findings support its use for weight management and the treatment of pain with obesity and moderate to severe pain due to knee osteoarthritis. I think this is a really important study. There is significant biological plausibility about why this treatment should work for this condition. And although it's a relatively small trial, and I dare say it's going to need to be scaled up and repeated on a larger basis, but the reality that these incretin-based drugs are so far focused on weight and metabolic issues such as cardiovascular disease, PCOS, diabetes, etc., but this significantly shifts the focus away from that and introduces it as a treatment for musculoskeletal conditions as well. Soon, it's going to be hard to find an indication you shouldn't give these drugs for, which really should act as a reminder about the root cause of these problems, which is, of course, obesity. And it still feels like, although we've got these new medications coming through and we're going to have dozens of them in the next 5 years or so, and the NHS is potentially going to be spending billions of pounds each year on these drugs, remember that you need to stay on them if you want to keep the weight off and therefore presumably keep the benefits of that reduction in pain in your knee or that reduction in your risk of cardiovascular disease. So we're spending billions and billions, but still you're failing to see any impetus on tackling the root causes of obesity. And if we ever want to get out of the spiral of this ever escalating cost of treatment here, then we're really going to need to get on top of that and build that into part of this national package. The other thing we've got to be really mindful of as prescribing clinicians is mission creep. And this feels like a recurrent theme with these medications. To be included in this trial, you needed a BMI of 30 or greater. But most people had a BMI of around 40, which is a really big difference. When this drug gets licensed, as it inevitably will do for this condition, on the licensing, because of the study protocol inclusion criteria, it's realistically going to say use from a BMI of 30 or greater. And this is why it's really important for us to be aware about study population demographics, because it's often quite different from what we're being told we can prescribe these treatments for. We've also seen similar happen recently with respect to the SELECT trial. So you remember that was semaglutide and cardiovascular outcomes in people with obesity. So they showed a marginal improvement with the use of semaglutide compared with placebo. In the protocol, they were recruiting people with pre-existing cardiovascular disease and a BMI of 27 or greater. That's who it's now been licensed for in the UK. But in the actual study, the average BMI was 33, which is quite a substantial difference. It sounds in my head like I'm being really negative about these medicines, and I don't mean to be, because as this new study shows, actually, there's lots of positive findings about them. But I just think when we're prescribing them, not least if we want to avoid bankrupting the nation, we need to be mindful about the people that they are genuinely going to work in, rather than the group that the manufacturers might wish us to prescribe in. Time, I think, to move on from GLP-1 receptor agonists, and let's look at a different study showing a different drug is actually better for managing a condition than a GLP-1 receptor agonist. This is a new paper published in the BMJ this week titled Comparative Effectiveness of Sodium Glucose Cotransporter 2 Inhibitors for Recurrent Nephrolithiasis Among Patients with Pre-Existing Nephrolithiasis or Gout. Target Trial Emulation Studies. Okay, let's get the first point out of the way. What on earth is a target trial emulation studies? Well, damned if I know. This is basically a cohort study using data from the population of British Columbia in Canada, and they were looking at patients with type 2 diabetes and kidney stones, plus or minus gout, who may then have started on an SGLT2 inhibitor or a GLP-1 receptor agonist or a DPP-4 inhibitor, which the hypothesis is that the SGLT2 inhibitors should be best and the other two worse, and therefore they're using the latter two as comparators. To set the scene for this study, apparently 1 in 10 people in the US now have kidney stones. I don't know what the UK prevalence is, but you'd imagine it's pretty similar because the main drivers are obesity, diabetes, and metabolic syndrome, of which we have an abundance in this country. Gout is also a strong and independent risk factor, which is why they've stuck that on the list of things to look at. Why should SGLT2 inhibitors help kidney stones? Well, we know all about their cardiometabolic renal benefits. It turns out they also reduce serum urate levels as they make the body excrete more uric acid in the urine. Now, GLP-1 receptor agonists have lots of potential benefits, but this shouldn't be one of them. The researchers then identified 20,000 or so patients who met the inclusion criteria for the studies. 3/4 of them had received an SGLT2 inhibitor and about 1/4 of them a GLP-1 receptor agonist. Recurrent kidney stones occurred less in the SGLT2 inhibitor group by about 1/3. If you want absolute figures, the rate was around 105 recurrent nephrolithiasis events per 1,000 person years in the SGLT2 inhibitor group. So that's about 10%, isn't it? Remember, this is, I guess, a high-risk population because they've already had a kidney stone. That's how they've been pulled into this data set. And that compares with a rate of 156 per 1,000 person years in the GLP-1 receptor agonist group, so about 15%. The difference is about 5%, giving a numbers needed to treat of 20. Now, that's not bad, a numbers needed to treat of 20, but it's even better if you have a history of recently active stones. So then it's a numbers needed to treat of 5. They also found a similar reduction of about 1/3 for the rate of gout. So they concluded that the benefits associated with SGLT2 inhibitors for patients with nephrolithiasis in these target trial emulations suggest that they may be a useful addition to current treatments to simultaneously manage nephrolithiasis recurrence and comorbidities, including gout. This sounds like pretty good news because, let's be honest, there's limited treatments for people who get recurrent kidney stones, a problem which is really pretty miserable. Should all of them get an SGLT2 inhibitor? Well, maybe. Actually, I don't really know. What I forgot to say at the start is they were only looking at patients with type 2 diabetes. So that's how they could collect this data and then turn it into one of these emulation target trials. So they haven't done a randomized control trial in patients with recurrent kidney stones and then started them on an SGLT2 inhibitor or started them on a GLP-1 analog. They're looking at patients who have type 2 diabetes and needed some treatment for that, and then pulled out the people from that cohort who had kidney stones and then looked at the effects that different treatments had on them. What it does mean is if you've got a patient who is already on metformin and you need to intensify their diabetes treatment, plus they've got a history of gout or of kidney stones, then an SGLT2 inhibitor looks like it would be very much the preferred option. And I think probably it further supports this idea about dual therapy from the outset of type 2 diabetes, using metformin and SGLT2 inhibitor, particularly for those comorbidities. Let's be honest, most of these patients are going to be at higher risk of cardiovascular disease as well, given the fact that it's all part of a similar metabolic syndrome. With a little bit of mindful prescribing, we can get them back on the cheese and pheasant in no time. Finally, in the podcast today, we're going to be thinking about prostate cancer, about PSA, and about a new consensus paper that's been published recently in the BJGP, which has been put together by a whole range of healthcare professionals, patients, and interested parties, all facilitated by Prostate Cancer UK, who is also the sponsor of this section. And I'm lucky enough to be joined by two experts in this area. So I've got Alex Norman, who's a GP, and Oliver Holson, who is a consultant radiologist. And I'm going to let them just introduce themselves to the audience today. So maybe let's go with Alex, purely because you're at the top of my screen, Alex. There's no favoritism here.
Cool. Thanks, Neil. So, hi, Alex Norman. I'm a GP in Surrey, and I also work as a co-medical director in primary care at Surrey and Sussex Cancer Alliance. And I've also been doing some work over the years with Prostate Cancer UK now as part of the consensus statement and their clinical advisory group.
And Oliver?
Thanks, Neil. Thanks for the invite today. I'm Ollie Hulson. I'm a radiology consultant in Leeds Teaching Hospitals. I spend far too much time that is healthy thinking about the prostate. I specialise in prostate MRI and prostate biopsy. I'm involved in our prostate brachytherapy service as well. And along with Alex, I've been working with the team at PSA UK for a few years now on a number of projects.
And Ollie is literally between prostate cases right now. So we're very lucky for both for him and Alex to find some time to talk to us today. Let me just set the scene then. We're thinking about PSA here, and I don't know about you. When I'm thinking about PSA, what springs to mind is that it is a deeply flawed investigation, and whilst men can have a check for it for prostate cancer, they probably shouldn't. And this is the message that seems to have been hammered home to us in general practice over the last few years. But the problem we've got is it's the only initial test that you and I have available to us to check a man for prostate cancer. I suppose you might say you could do a digital rectal exam, but if you want to know how bad they are at picking up cancer in asymptomatic men, then have a listen to the podcast we did on exactly this a few months ago. I will put the link in the podcast description. And so that brings us on to this new paper that's been recently published in the BJGP that was from August. And this is all about optimizing the use of PSA blood tests in asymptomatic men for early prostate cancer detection in primary care. So Alex and Ollie are two of a group of authors of that paper, so they really are the experts here. So maybe let's bring in Alex then. So Alex, why was this consensus paper needed?
Well, I think you summarised it quite well there, Neil. This is that through medical school and over the years, doctors have often talked more about the harms of doing PSA testing rather than the benefits. And we often keep that knowledge and struggle, because there's so much going on, to be aware of the most up-to-date things that are happening on cancer pathways, and particularly prostate. And things have changed. We have got better pathways, and we're aware more of high-risk groups. And although there was the prostate cancer risk management program that was a guidance document that suggested that any man over 50 could ask for a PSA. It didn't really address a lot of the issues in men under 50, those with a strong family history, black men. It wasn't around at the time when the MRIs were changing the pathway and making it a lot less likely that you're going to get complications. And also we've seen a real change in people coming forward from deprived areas where the prostate cancer prevalence is much higher. And so we felt as though it was time to try and support a consensus statement to try and influence guidelines. So we got together with Prostate Cancer UK and produced this consensus statement.
It's interesting that because you mentioned the prostate cancer risk management program. That's something that I've always used when counselling men about whether they would be interested in having a PSA test to be checked for prostate cancer. It strikes me that there's been a lot of changes recently in the technologies available to us in the sort of assessment of prostate cancer. And one of the limitations of these guidelines, like the prostate cancer risk management program, is it always seems to be behind, and often it all takes a lot of time, and often it takes years and years and years, and then we have this kind of gap between what is possible and kind of what we're doing at the moment. So I know that PSA hasn't changed, but maybe Ollie, now's the time to bring you in. What has changed in the pathways for prostate cancer?
Thanks, Neil. I think Alex summed it up really nicely from the primary care point of view. And I'm married to a GP. We know that PSA is a useful test, but it's not a perfect test. And I'm conscious that your audience is predominantly GPs, but there may be nurses and healthcare assistants dialing in as well. So I don't want to dumb it down too much, but as the name suggests, PSA is specific to the prostate. And so people without a prostate don't make PSA. But unfortunately, it's not specific to prostate cancer. And most men with a raised PSA will not have prostate cancer. If we turn back the clock 10 years or more, if a man was worried about prostate cancer, he would have an examination, so a DRE, and a PSA. And if the examination was abnormal, or if the PSA was raised, he'd then go on to have a transrectal or truss biopsy. There was a small but significant risk of infection and life-threatening sepsis with a truss biopsy. And it was the PROMISE trial, led by the team at Imperial, that found that truss biopsy could also miss significant cancers. And MRI not only found cancers that could be missed at the biopsy, but more importantly, if a man has a normal MRI scan, the chance of him having clinically significant prostate cancer, that means a cancer that we want to treat that will affect life expectancy, quality of life, etc., is very low. So in addition to this, in the UK, we've been leading the way internationally for the move from transrectal biopsy to transperineal biopsy. So instead of passing the biopsy needle through the rectum and the obvious risk of infection, we now pass the needle through the skin overlying the prostate. So the risk of infection is significantly reduced. And also we can access parts of the prostate that we couldn't access previously with truss biopsy or were very difficult. So we've got a safer, more effective biopsy technique, and we offer pre-biopsy MRI as a standard of care. So not all men referred with a raised PSA will need a biopsy. Those men that do have a biopsy are having the best biopsy possible in the UK right now.
So that's then changing this risk-benefit profile for doing the initial PSA test in primary care, isn't it? So we're on the one hand, we're making it safer. We're also making it more accurate, is that right? So we're hopefully reducing the rate of overdiagnosis whilst reducing the chance of missing important cancers.
Definitely, yeah. So from my point of view, I think that the scales have tipped, the pendulum shifted in favour of early PSA testing in the right men. So, we have some patients, 75 years old, want their PSA getting checked every 6 months, and it's been one for years. Clearly, that's a different conversation to be had. But we know men over 50, even if they're asymptomatic, are entitled to a PSA test. And what I want to do is break down those barriers, because we have good quality pre-biopsy MRI in the UK as standard of care now. And most centres are making the shift towards transperineal biopsy as well. So the arguments against early PSA testing are vastly diminished.
So maybe let's come back to Alex now then. So what were the key outcomes or the key messages from the consensus paper?
There is no screening program for prostate cancer, but the consensus statement feels as though the dial has shifted towards being more proactive in those discussions. So previously it was the requesting patient for the PSA, but now GPs should be more proactive in asking higher risk groups, i.e. black men who have a 1 in 4 chance or twice as high risk of getting prostate cancer, and those with a strong family history, that the GP proactively says, have you had a PSA check? As well as raising awareness more in those groups through public awareness campaigns that they are at a higher risk of prostate cancer. So it's supporting those proactive discussions in those 50 plus men and 45 plus in higher risk groups. We should really try and make sure that healthcare professionals who are having this discussion, like Ollie said, give balanced information with up-to-date knowledge of the pathways, i.e. that the dial has shifted towards less harms because of active surveillance, better use of MRIs, etc., transperineal biopsies, less complications, and trying to dispel those myths of the harms that might be done from a PSA blood test. Coming back to the rectal examination, we reaffirmed if a PSA is up, not to do a rectal examination, but to refer in on an urgent suspected cancer. And we've also said that actually we are asking primary care to do a lot of work here. Primary care should be well resourced to support those conversations, to deliver PSAs to areas, particularly as I highlighted, areas of deprivation where people are not getting diagnosed with prostate cancer earlier, and we'd like to try and support that shift.
I think the point about DRE is really important. Anecdotally, I see men who've requested a PSA test for one reason or another. They're concerned or they have symptoms, and they've been to see, the GP or the practice nurse, and they've said, well, we need to examine your prostate. And they say, not over my dead body. Are you putting a finger into my rectum? And they say, well, we're not doing a PSA test then. And what we've seen now with the shift to pre-biopsy MRI, a lot more remote consultations, both in primary care and in secondary care as well, is that the DRE is fast becoming a dying art, I think. I examine prostates of every man I do a biopsy on, and these are men with sometimes advanced disease, T3 and T4 disease. Am I convinced that I can feel an abnormality? Not really. I must have examined 300 prostates this year. So I can't expect the same from primary care. And my issue with a DRE is, at best, you may pick up a craggy hard prostate. So you've been diagnosed advanced prostate cancer, at presentation, I guess. At worst, it can be falsely reassuring. And I do hear occasionally, you have a raised PSA, but your prostate is enlarged on examination. That's fine. With all the best will in the world, you cannot exclude prostate cancer with a DRE. And that shouldn't be a reason not to do a PSA test and not to refer men on. Can I just comment on DRE relating to black men specifically? We've done some work in the community in Leeds looking at engagement. And one thing that came up time and time again is the reluctance for black men to have a DRE examination. And that would be something that they would be put off going to their GP to discuss their risk of prostate cancer and having a PSA test.
Well, I think that's really important knowledge for us. It just goes to show the importance of individualizing care. If we're so rigid in our management, as in this person doesn't want this, so therefore we won't give them that, then all that's doing is forming barriers. All that's realistically doing is driving health inequalities. And of course, that's something we really want to try and battle against. While I'm sure it's true that some things in general practice can take quite a long time to change, actually sometimes change can happen pretty quick. And I reckon not doing a digital rectal exam as the first step in the assessment of whether an asymptomatic man has prostate cancer or not is going to be one of those quick changes. Let's be honest, no one's going to miss not doing a digital rectal exam when it's actually not helpful. Really important then that we understand that as clinicians. Really important, I guess, that message gets out there to the public as well. I'm sure it's not just the black community who is put off coming to the doctors because of the thought of having to have a rectal exam. So yeah, this is a really important message to get out there to everyone. Start with a PSA.
I think this is a good message, Ollie, because quite often on other cancer pathways, there can be some criticism of sending patients in without an examination. Here, actively saying, actually, you've taken the history, you've done the test is up, send them in. Don't delay. No other sort of holes where we might lose patients. Get them in on USC. We'll see them. The tests are better. Bit of reassurance there. So that's thanks for that, Ollie.
Yeah, definitely. And I know, I see how hard my wife works. She works longer hours than I do. She has 70, 80 patient contacts a day compared to my 3 or 4. And 1% of what she does will be prostate cancer compared to 90% of what I do is prostate cancer. Yeah. So it's about sharing that burden and saying, actually, you're pretty swamped in primary care. Let us take some of that burden for you. And if you can check the PSA, we'll deal with the rest of it.
This also makes me think about other areas like the NHS health check. I know that you and I know there are questions around how useful an NHS health check is, but perhaps you could make it more useful. Perhaps prostate cancer could be an area that could be added to the NHS health check. Not so much that you must have a PSA test as part of it, but rather maybe this is an opportunity to think about those risk factors. And if they say yes, then perhaps this is an opportunity for us to then go on and do that PSA test.
Just off the back of that, Neil, I absolutely see more people asking for it via the NHS health check. And I think so long as they are cancelled, then that's absolutely fine. But the awareness is getting out there, and you're right. I'm definitely seeing that just in my daily clinical practice, that people are saying, oh, could I possibly have? And that's good to see.
Okay, so maybe let's go back to Ollie. Do you think all this changes the case for screening for prostate cancer in the UK?
Yeah, I think that's a really good question, Neil. There's been 2 very large trials performed in the past, so the ERSPC trial and the CAP trial, which did prove a survival benefit when testing men for PSA, but some of the criticisms of those trials relate to overdiagnosis and overtreatment. Prostate Cancer UK and the NIHR have put forward an awful lot of money to the tune of £42 million for the Transform trial, which is looking at screening for prostate cancer in men in the UK. They've not released all the details as yet. We might hear some more details later this year or early next year, but I think it's likely that MRI will play a large role in that. And I hope that the results from that trial are positive, and perhaps maybe 10 years from now, we do see screening, particularly for men most at risk of prostate cancer.
Okay, to summarise our conversation, we've got this new consensus paper that focuses on asymptomatic men and optimising the use of PSA blood testing. For now, PSA is still the only test we've got to start the process of looking for prostate cancer. It isn't a perfect test, but new technologies such as multiparametric MRI can lead to reduced overdiagnosis and unnecessary biopsies. The transperineal approach, if you do need a biopsy, can make it much safer. And this changes the balance of the risk to benefit of doing that initial PSA test, making it certainly much more favourable. We need to be thinking about risk factors, so particularly in black men, those with a family history, a history of BRCA, and perhaps we should be more proactive in offering these men PSA tests. Also, we want to be aware that prostate cancer demonstrates significant health inequalities with higher rates of late-stage diagnosis in areas of deprivation. So perhaps this could be a nice area to do a bit of quality improvement in your practice on. And then finally, we don't necessarily need to do that digital rectal exam. That's going to be really welcome news for all of us, I'm sure. So do that PSA test first. If it's raised, there's no benefit of doing an exam. They need to be referred on an urgent cancer pathway. If you want to take a look at that consensus paper, I'll put the link in the podcast description to the BJGP article. Also, I'll put a link to the Prostate Cancer UK website. They've got an online learning platform which has got loads of information if you want to upskill about prostate cancer, PSA testing and everything else that you can think of. Go and have a look at that too. And it just leaves me to say Thanks so much to Ollie and to Alex for coming on the podcast today. It's been great to have you along and for you to share your expertise.
Thanks very much, Neil.
Yeah, thanks for the invite.
And thank you to all of you at home who have been listening today. I hope you've enjoyed this podcast. Remember, you can always get in touch. Email gphottopics@nbmedical.com. You can find us on Facebook, Twitter, and I'm told even YouTube if you so wish. Have a great weekend, everyone. Look after yourselves. We'll see you next time. Bye-bye.